And you're very welcome to episode number 42 of the HVA podcast. So as always, all links, show notes, anything we talk about in the show can be found over on our website, www.hvascience.com/episode 42. So if you're new to the show this week, firstly, thank you so much for coming on and downloading it. I really appreciate it, and I hope you enjoy what we do here. What you can expect to find is discussions on a weekly basis with world-leading experts, practitioners and researchers in the areas of health, nutrition, performance, and from time to time business development for the fitness professional. And we do this all from an evidence-based practice approach. So this content will come to you on a weekly basis for free, and it will always be free because I strive to bring you the best level education I can to increase your knowledge in a range of different topics from a range of different industries. So if you could spare 2-3 minutes, I would really appreciate if you could go over, leave us a review on iTunes, comment on this video below if you're on YouTube, and just help develop the show and tell us what direction you'd like us to bring the show and bring you the very best that we can bring you. So on to today's show. I had the absolute pleasure of being joined by Dr. Bobby Cheema, and he's a senior lecturer in sport and exercise science at the University of Western Sydney. So Dr. Cheema's work as a clinical exercise physiologist has mainly been focused on using exercise as both treatment and prevention in a range of different diseases. So his research mainly looked at renal disease, type 2 diabetes, cancer and a range of metabolic diseases. So firstly we get in to talk about whether exercise is something that is really underestimated in the healthcare and medical system, whether we have an over-reliance on pharmaceutical methods of treating disease, and whether we should switch from maybe a very reactive system that we have now in the healthcare system. Because if you think, we tend just to view healthy as the absence of disease. So in the healthcare system, we're very reactive. We wait for someone to get sick, then we start about treating them. Whether we should kind of flip that on its head and we should get very proactive or preventative. Use exercise and nutrition to stop the disease occurring in the first place and stop viewing health as just the absence of disease, but rather health as a complete physical, emotional, mental well-being, and whether that shift needs to happen within the medical system. And then we talk about the role that the exercise physiologist may play in this. And then we kind of narrow down and get very specific and talk about the role of exercise in cancer. So we talk about how exercise may improve life outcomes, quality of life and clinical outcomes for people undergoing cancer treatment and then for cancer survivors. And what I love about these type of conversations, you never really know where the conversation is going to bring you. So myself and Bobby never really intended to talk about the role of muscle mass, but that's exactly where we ended up going. We started talking about the importance of the muscle mass and maintaining strength and muscle mass in a range of different diseases and just for quality of life. So we start weighing up the pros and cons of aerobic versus resistance training, and whether again there needs to be a mind shift where we need to primarily start emphasising the role of resistance training in disease prevention and disease treatment. So it's a very interesting episode today. I hope you really enjoy it. Let's get into it with Dr. Bobby Cheema. It's my absolute pleasure to be joined by Dr. Bobby Cheema. Thanks so much for giving up your time and having a quick chat with me today, Bobby.
Oh, my pleasure, David. Thanks for having me on.
So for people who may not be familiar with your background, if you'd like to give us just a quick synopsis of your background and then the current work you're involved in now.
Okay, so professionally an exercise physiologist, PhD qualified. I started studying exercise physiology at about the age of 18. I'm 43 now, so I've been studying and teaching exercise physiology for about 25 years now. Born and raised in British Columbia, Canada. I moved to Sydney, Australia in 2003 to start my PhD. Completed that in 2006. Most of my research is in the area of clinical exercise physiology. So the populations that I've worked with so far, largely around cancer, prostate and breast cancer specifically, and also mostly around metabolic disease. So everything from polycystic ovary syndrome to type 2 diabetes, and also chronic kidney disease as well. So that's kind of my background in terms of a professional sense. And I've been teaching at Western Sydney University since 2009.
Brilliant. And that opens up the scope of what we're going to be discussing about today. And this is the idea of disease, chronic disease, and then the role of exercise and the role of exercise professionals in the treatment of this. So just so we have everyone on the same playing field, Bobby, at the start, the term non-communicable disease is something that we often hear, but what is the definition of that?
Yeah, so basically there's communicable and non-communicable diseases. Communicable diseases are diseases that can be transmitted from one person to another, whereas non-communicable diseases cannot. Now, in terms of the impact of non-communicable diseases currently, it is a massive influence. So currently, approximately 70% of deaths internationally are attributed to non-communicable diseases. And the leading non-communicable diseases include cardiovascular diseases, cancers, diabetes mellitus, and kidney disease. So that's basically, what we consider to be lifestyle-related diseases. So in terms of non-communicable diseases, they are primarily, in terms of the major ones today, they're primarily lifestyle-based diseases.
So from that, we can extrapolate that a huge amount of kind of the diseases that ravage our society at the moment are preventable essentially through our lifestyle choices and altering our basic habits and lifestyle.
Oh, without a doubt. And in terms of prevention, the earlier the better. Unfortunately, our Medicare system is largely a reactive system, so we let pathologies like physical inactivity and overweight obesity manifest over the years. And of course, the end product of those conditions, along with poor diet and high levels of stress, is the diseases that I just mentioned, so cardiovascular diseases and metabolic diseases and cancers being the leading ones.
Exactly, and that's something we're going to get into later on the podcast. But first of all, your background's obviously in clinical exercise physiology. So exercise kind of, in general, it seems to be by the health profession, something that we add on. It's kind of an adjunct to say it's always a recommendation at the end and make sure you get enough exercise and eat properly. But do you think that the role of exercise is maybe underestimated in both the treatment and prevention of diseases?
Oh, without a doubt. And I would go so far as to say it's probably the main thing that's missing from today's medical system. So, everything from treating psychological conditions like depression and anxiety to highly specific biochemical related pathologies in terms of inflammation and inflammatory markers. The evidence for exercise is just so vast now across a number of chronic conditions and certainly in the area of disease prevention as well. So without a doubt, I can't think of a single disease that is manifest today in a large way in terms of impacting the population where exercise does not have a place. Exercise has a place across the entire spectrum of chronic conditions that we're dealing with.
And if we've such a body of research that's supporting the efficacy of exercise, then why is it that the medical system seems to be very hesitant and underestimate exercise? Why do you think this underestimation exists?
Well, there's many reasons. I think the main reason is the way medical education is basically delivered. Medical education is basically governed by institutions that have high affiliation or are basically linked to the pharmaceutical industry. And the reason that exercise is not a bigger part of the healthcare model is because simply it can't be patented for any kind of financial gain. So basically what we have is, in terms of medical treatments, medical intervention, the medical system, so to speak, is basically industry influenced and industry sponsored. And that's basically how it's governed. It really has nothing to do with health at all. I think health is a very strange way to describe it because it's nothing more than a disease care system. If you look at the definition of health by the WHO, for example, it's a complete state of physical, mental, and emotional well-being. Well, certainly our medical system falls well short of actually providing any kind of health treatment in any respect. It's all symptom, basically the alleviation of symptoms, symptom relief. Yeah.
So essentially, do you think we need a global shift in maybe our attitude towards healthcare? Because we tend to be very reactive as such. Rather, when people get diseases, that's the only time we start worrying about them in the healthcare system. Should we be shifting more towards a kind of progressive system where we prevent a disease occurring in the first place?
I think that's starting to happen, and this is not a shift that I expect to see from the top down. It's a shift coming from the ground up. So, There are people paying more attention. Certainly, if you ask the average person, they'll say that exercise is good for them. So there is a growing awareness that, engaging in an active lifestyle and engaging in exercise training is going to be beneficial. And certainly there is a movement towards eating better, eating organic foods. You have the whole food movements happening all over the world. But this has not become the norm yet. So I think the people who have shifted towards that mindset are largely people who have, the time to pursue physical activity and exercise, the wherewithal, so the money, and also the education. So in affluent suburbs, in affluent parts of the country, you are seeing that shift being taken place already, and that's great to see. Unfortunately, I don't think it's reached the average citizen as yet.
And in terms of doctors, obviously seem to be put up on this pedestal of being the pinnacle of the healthcare professional to give you advice. But anyone that actually looks at medical training, as you said, it's very much influenced by the pharmaceutical company. And a lot of doctors aren't actually given formal training within exercise, and they don't understand the principles of training and the more complex exercise training methodologies. So as an exercise physiologist, do you believe that there should be more of a shift? Because I know Australia is very progressive in terms of the use of exercise physiologists integrated into the healthcare system. So maybe globally, what role can the exercise physiologist play in disease prevention and management?
Well, it's starting to happen. I think the interest from physicians that I've seen over the last 5 years has been unprecedented. The interest in exercise. How do we get exercise into our clinics? So I've been approached by physicians ranging from oncologists to endocrinologists to nephrologists who are basically saying, what can we do for our patients? So the opportunity is there. As far as Australia goes, I see most exercise physiologists, even though that they're clinically trained, they are largely working in private practice. So their affiliation is not necessarily with a hospital or a clinic per se. They've got their own clinic in terms of the private practice clinic outside of the clinical, so-called clinical setting, the hospital setting. So there's a lot of work to be done there. Certainly there is evidence to provide exercise across a number of diseases, including diabetes, including chronic kidney disease and end-stage renal disease, and including cancers as part of standard practice. Okay, so that evidence base is there, and in many of these conditions, it dates back about 40 years. So it's been a slow process, but I think the interest is there. It's just a matter of actually gaining the funding to hire exercise physiologists within those settings to deliver care.
Brilliant. And if we go now into a more disease-specific focus, so I know a lot of your research has been into the role of exercise in certain cancers. So what does the current body of evidence say about exercise in cancer patients?
Yeah, so the current body of evidence, this body of evidence has been evolving since the early 80s. The first study that I saw published in a cancer population was published in 1983. So the data has been there for a number of years, and it has gotten stronger and stronger over the decades. Specifically in terms of that body of evidence, it's largely focused on safety and efficacy. So in terms of safety, exercise has been demonstrated to elicit very few adverse events. Those adverse events tend to be musculoskeletal in nature. No serious adverse events over that 30-odd years of data collection. Beyond that, the efficacy has been demonstrated by the investigation of a number of clinical markers, ranging from psychological outcomes like quality of life, depression, anxiety, to physiological markers like inflammatory markers, changes in maximal oxygen consumption, changes in other hematological markers, and also functional markers. So the ability of a person to function in daily life. So, sit to stand performance, 6-minute walk performance, things like that. Overwhelmingly, the data has been extremely positive.
And if the evidence is so supportive, do you think that there still seems to be a lot of hesitancy about allowing cancer patients to engage in exercise? Maybe I know self-confidence seems to be a lot of issues with cancer patients. So from your experience, do the patients themselves or their families, do they tend to be very hesitant in allowing themselves or either their family members to start engaging in exercise while undergoing cancer treatment?
Yeah, certainly, and I think there's some psychological barriers that are definitely, have to be addressed, and have that person to become motivated enough to get up and out of the chair or out of the bed and take those first few steps, certainly. But yeah, there is hesitancy, and I think just the evidence base is just so strong that there is no doubt that even within the middle of chemotherapy treatment, for example, as you mentioned, it is worthwhile, and we know that exercise is the best remedy, certainly a very, very strong remedy for cancer-related fatigue. So whereas fatigue was previously used as an excuse, we now see it as an indication for that person that actually needs exercise. So, a lot of the barriers are just kind of psychological, as I say, and just need to be addressed. But I think the thing that can facilitate that the most is if that positive reinforcement comes from all levels. So you mentioned the physicians have a very, very important role to play in a patient's life. So if that message is reinforced by the physicians, it's even stronger. If it's reinforced by the nurses, it's even stronger. If it's reinforced by the exercise physiologist, of course, even stronger. So if we're all on board with that message, I think that patient is going to be able to overcome any kind of psychological challenge that might be in their way.
Yeah, and there's one point there I'd really like to reiterate that you said, Bobby, and that is we know that chemotherapy is very fatiguing, and we have this cancer-related fatigue. And just to kind of get the point across to anyone listening, exercise does have a paradoxical effect with cancer-related fatigue. By actually exercising, we seem to alleviate some of that fatigue. So that's one thing I'd just like to reiterate with people, that by exercising, you actually have a very good chance of reducing your fatigue associated with cancer treatment.
Yes, definitely. And there's been a couple of meta-analyses published on that very topic, published in the last couple of years that are very high impact. So the data is very clear and very consistent.
And as you said, exercise is safe for people in cancer or people with cancer. So if anyone is listening that their family members is undergoing cancer treatment or themselves, what considerations, do they have any other considerations that they need to take into account that's kind of unique to them? Or is it just the general considerations people need to undertake when starting an exercise program?
Well, in general, the considerations are around, the general absolute and relative contraindications to exercise. So if they don't have any of those absolute or relative contraindications to exercise, relative contraindications can be superseded if the benefits outweigh the risks of exercise. So that should be worked through with a healthcare professional and a physician to see if that person is presenting with any potential contraindications. In addition to that, the ACSM, so those guidelines have been developed by the ACSM for absolute and relative contraindications. That's the American College of Sports Medicine. In addition to that, the ACSM also published a cancer-related position statement on exercise. It wasn't a position statement per se, it's a roundtable discussion about exercise in cancer, and that also has recommendations as to any potential adverse events that the person has encountered or any potential contraindications that they might have that may preclude their participation in exercise. But in general, I mean, most patients do meet the criteria for engaging in exercise, and I would say upwards of 90% of them, if not more. So
perfect, and I put the links to the roundtable and that in the show notes for people to find. And what modalities of exercise appear to be most beneficial? Is there a particular mode of exercise, be it cardiovascular or resistance based, or what type of exercise should these populations engage in?
Yeah, with the body of evidence to date, the emphasis has largely been on cardiovascular conditioning. My take on that is, I really have no bias. I mean, I'm not partial any which way based upon the research that I've done. But in terms of the physiological effects that can be gained through resistance training, I actually outrank cardiovascular training with resistance training. I rank resistance training number one. Resistance training is such a potent form of exercise, and it is the real key missing ingredient to a lot of people's exercise regimens. I mean, I've seen endurance-trained athletes, and they train and train and train, and no weight training, and they basically burn themselves out. And I've seen many people in their 60s and 70s basically, die because that's all they're doing is just that with cardiovascular conditioning. To maintain muscle mass throughout old age, there's only one antidote for that, and that's resistance training. And so because muscle tends to reduce after about the age of 25, 30, that's why I rank resistance training so strongly in terms of our metabolic rate, in terms of our ability to alleviate stress on our joints, so reduce the risk of osteoarthritis, in terms of our body composition, in terms of our, just overall sense of well-being and quality of life. So much of that is linked to muscle mass. So much of our metabolism is linked to muscle mass. And the best form of exercise for muscle mass is resistance training, without a doubt. Cardiovascular conditioning, I would say, in terms of health, if a person is very strong, they've got good, strong muscle mass, they're going to be able to engage in more and higher levels of cardiovascular conditioning. So in my view, the weight training comes first. Cardiovascular conditioning comes second. In terms of breaking down cardiovascular conditioning, certainly there's a lot more evidence in recent times to suggest that high-intensity intervals are particularly important for cardiovascular system health. So that includes arterial stiffness, so reducing arterial stiffness to a better extent than moderate to low intensity or low to moderate intensity aerobic conditioning, and also heart health in general. So those intervals, the high-low, seems to improve the remodeling of the heart to a much greater degree than low to moderate intensity continuous training.
Brilliant. And this high-intensity interval training, once, say, someone that's undergone cancer treatment or a survivor of cancer, once they're cleared for exercise, is there any problems with those type populations engaging in this kind of high-intensity training? Because I know a lot would be very hesitant to engage in such exercise.
Oh, definitely. But the thing that people have to remember is that intensity is basically relative. It's relative to that person. So whatever they deem as high intensity and whatever their physiology deems as high intensity in terms of their heart rate, that's what high intensity is. And in actual fact, the study that I mentioned in 1983 was done in a group of breast cancer patients undergoing chemotherapy, and that actually was interval training. So the interval training has been prescribed, since the early 80s in this cancer population specifically, and it clearly was safe and effective for them to do that.
Brilliant. And one thing I'd like to kind of backtrack on there that we touched on, and maybe it was something that we were going to go down the avenue of discussing today, but I think it's a very worthwhile topic. And a lot of your kind of background is in metabolic health, as you said, and metabolic diseases. And you touched on the importance of muscle mass as we age. And we know that a more progressive healthcare system would look at the use of exercise as we age. And a lot of people, when they start getting into the elderly or their parents, start to focus on heart health and this kind of stuff. So they're getting a walk and jogging, and all they seem to be obsessed with is looking after their heart. But how important is the maintenance of muscle mass to our overall health and our metabolic health as we age?
Yeah, the first point I'd like to make is that the muscle is connected to the cardiovascular system. That's where your energy actually ends up. The carbohydrate, the fat that you're burning, the oxygen that you're delivering it to your muscle. Metabolism takes place in the muscle. So the muscle is part of the cardiovascular system, believe it or not. So in order to utilize more oxygen, one of the things that the scientific research has shown is that people do have limitations extracting oxygen at the peripheral level. So this is within the muscle itself. So the more robust, the more dense with mitochondria that muscle is, it's actually able to absorb more oxygen. So the emphasis on cardiovascular conditioning, I can say, is that the person will not be able to work at such high intensities unless their muscle mass is robust. So very clearly, cardiovascular conditioning goes hand in hand with muscle mass, but and you will get some benefit to your muscle mass through cardiovascular conditioning. There's no doubt about that. But in terms of really modifying that and alleviating the age-related deterioration of muscle mass, which is termed sarcopenia or flesh wasting, you've got to engage in resistance training. There's really no two ways about it. Muscle mass, the atrophy affects both type 1 and type 2 muscle fibers, and that results in a reduced ability to metabolize energy. essentially. So I cannot overemphasize this enough. I think it's the main missing ingredient in most people's exercise programs, whether they be elderly or not. And once people start doing it, I mean, I train women in their, basically from their 20s to late 50s, just out of my garage. And many of them are very physically fit, and they cannot believe just doing resistance training once or twice a week how much benefit they actually get from it. Even in terms of the running performance. I mean, I'm talking about women who basically run every day, how it's benefited them in terms of the running performance. And these are not older women; these are just women in their 30s, but their muscle mass is starting to, go down. They're at that age. It is highly important, and that's why I rank it number one.
Yeah, and it really is the benefits of resistance training through athletic forms health. It really is starting to rise at the moment. And do you think resistance training itself, because we know that exercise is undervalued within the kind of healthcare system, people tend to underestimate its benefit. A lot of physicians that they are coming around full circle now. But then within exercise itself, do you think then resistance exercise itself is underrated by most professionals then as well?
I think so. It staggers me when I go to the ACSM conference how little coverage there is of resistance training. I mean, this is the biggest sports medicine conference in the world, and most prestigious, and there's very little coverage of resistance training. I think there's a lot of stigma around resistance training. I think resistance training is still kind of shedding its, the ideology that it's all about getting buff and standing up on a stage and flexing your muscles. And I think that stigma still exists for a lot of people. And particularly the populations that we've already been talking about, so the chronically diseased, even in women, that stigma exists. I don't want to get bulky, I don't want to look like that. But it's not the case unless you're, injecting copious amounts of steroids and eating, every 2 hours kind of thing. So I think the whole, showmanship around resistance training, what we call bodybuilding, has done a real disservice to the health benefits, or to basically the acceptability, the broader acceptability of resistance training as a health as a health antidote or a form to maintain health. So there's a lot of challenges, I think, to overcome that stigma. But clearly, once when I work with clients and when I work with patients, they're staggered as to how quickly they can improve and how good they feel just by, several weeks of engaging in heavy lifting. And that's the other point that I'd like to mention is, resistance training does have a very specific way to prescribe it for health benefits. And the intensity is the most important aspect. And those are the loads that people are lifting. And they've got to be heavy. They've got to be loads that, people can lift basically between 8 to 12 times per set to fatigue. And that induces the kinds of physiological changes that are really considerably beneficial to the overall health of the human body.
And just while we're touching on that, because I know a lot of people may be listening, and a lot of trainers will have, say, people in their 40s, 50s, 60s who are coming to them and are very hesitant to start weight training. So maybe the trainers could use this as something that they could direct them towards. If someone came to you in their 40s, 50s, 60s and are very apprehensive about starting weights, and especially about lifting heavy, what would you say to them? Because a lot of people will have concerns and kind of apprehensions about engaging in heavy weight training, because people picture resistance training for elderly people as these little pink dumbbells that they sit in their chair and lift. So what would you say to those people that are very hesitant in that perspective?
I think a lot of the the verbal dialogue takes place while the person is doing it. So just basically initiating them and not really overthinking it, I think is probably my approach. It's just like, get into it. I mean, I've had consults with patients where they just would want to talk for hours on end and just like go through all the scenarios. Well, what if this happens? And what if that happens? And what do you think about this? And what do you think? And just like, my approach is basically just, shut up and lift, to be very blunt, grab that dumbbell and just lift it over your head. And I think that develops confidence, and as they go, and then they come out the other end from that first session and going, well, that wasn't too bad, So it's more about, I think, just doing it. I think as a society, we're too focused on just debating and, going through the what ifs and what so, and, what's the theory, and, at the end of the day, just shut up and do it, I mean, that's basically what it comes down to for me.
Exactly, and it actually reminded me of a conversation I recently had with an exercise physiologist friend of mine, and he was saying that someone was talking to him about the risks of exercise, and he's like, any exercise we do, there's always going to be risks, but if you just take those risks and you don't do exercise, then you become obese, develop metabolic disease, and these kind of things that, you know what I mean, it's better off to take the risk, do an exercise, and living a healthier lifestyle than all the negative drawbacks of not engaging in this kind of thing.
Oh, absolutely. I mean, you might get some muscle strain, you might get tendonitis, you might get those kinds of niggly things come up. But overall, I mean, those are very, very minor by comparison to the diseases that we talked about from the outset here. I mean, you want cardiovascular disease in your 50s, diabetes mellitus. I mean, consequence of diabetes is basically, it can be in the end stages of blindness and amputation. So would you rather have a little bit of tendonitis or would you rather have an amputation? I mean, come on. And you're going to have a vastly improved quality of life by engaging in exercise. The other thing that I will emphasize is that exercise, your listenership will know this, is that exercise is a form of stress. So you do have to counteract that with an equivalent quality of rest. That's what the fitness industry tends to overlook, is that, you can exercise all you want, but if you're not sleeping and if you're not eating right, you're just working against yourself. You're actually eating away your own tissue. So that stressful, bout of exercise, has to be counteracted with the two main things are sleep and proper diet. So if that's not happening, of course, adverse events are going to come up, but, those adverse events, even if people are attending to their sleep and tending to their diet quite well, if they do experience an adverse event, that adverse event tends to be pretty minor in most cases. And resistance training is, because it's a very controlled form of exercise, it's very safe. It's certainly more safe than a lot of sports out there.
Exactly, and I like that you alluded to there. It's kind of that trifecta of nutrition, sleep, recovery, and the training itself, because there does tend to be an over-emphasis on people just focusing on the exercise, and nutrition then a lot will focus on that, but things like sleep and recovery tends to kind of get the backseat there as well. So you did mention, and I know you've background then in type 2 diabetes, or diabetes as a whole then as well, and that's another place where people often, I think, underestimate the role of muscle mass in diabetes. So what is the relevance of maintaining a good level of muscle mass for people with diabetes?
Oh, very important again. And the mechanism for diabetes, well, basically diabetes is an insulin-resistant condition. So the muscle goes insulin-resistant. Most of insulin acts at the level of skeletal muscle. Now, what deems a muscle insulin-resistant? Well, we know that diabetes is basically brought about by obesity. So obesity, the thing about obesity, though, is that the fat that gets accumulated into that person's system, some of it does reside within the muscle mass itself, within the skeletal muscle cells. Okay, so an insulin-resistant condition like type 2 diabetes, there is an oversupply of what we call intramyocellular triglyceride within the muscle cell. Okay, so there's an oversupply of triglyceride within the muscle cell, and that's what causes insulin resistance. So the more robust the muscle, the less intramyocellular triglyceride is impeding that insulin resistance. Okay, so we know in type 2 diabetes that intramyocellular triglyceride actually inhibits insulin signaling within the muscle cell. And the way to remedy that, resistance training has been shown to have an isolated effect. So isolated resistance training can alleviate intramyocellular triglyceride and insulin resistance, but the combination of aerobic and resistance training appears to be the best. And that was a randomized controlled trial in 2007 by Sigal et al., Sigal. So certainly, resistance training has its place. And what I deem as the important place of resistance training in diabetes is breaking down necrotic muscle fibers that are overloaded with intramyocellular triglyceride, rebuilding robust muscle fibers, and then the cardiovascular conditioning is about bringing in energy and basically utilizing and burning that energy in a better furnace, so to speak. So the muscle is the furnace where you burn energy, and the cardiovascular is basically the throughput. It's bringing the energy in, shoveling in the carbohydrate and the fat to be burned. Yeah.
Fantastic.
So go ahead.
And we're approaching their time, Bobby. So if we were to summarise, what would you say needs to be the big kind of shift that we would like to see in our approach to healthcare, and then as a population, what should be the kind of shifts and mentalities we should have to our preventing disease, and what role exercise plays in disease prevention?
Yeah, so I think within the medical system right now, the big challenge is the integration of exercise as standard practice. I think that needs to take place. I think it can happen now. There's no reason. It's just about acquiring the funding to hire a couple of exercise physiologists to deliver the services. So the integration of exercise as standard practice in clinical settings. So in the leading noncommunicable diseases that I mentioned, so certainly cardiovascular, cancers, diabetes, and kidney disease, it can happen, it should happen today because the evidence is there. In terms of the population, I think it's basically an issue of self-empowerment. People have to arm themselves with the best knowledge and the best tools to undertake those lifestyle-related changes for themselves and start living a healthier and happier life for themselves. And then through that personal empowerment, that spreads out to the community level, and then eventually, the national level and the global level. So it really, as I see it, it's a grassroots movement. It's starting to happen in Sydney. You can clearly see it in the eastern suburbs, which are the more affluent suburbs. You wake up at 5:30 and people are running on the beach, and they're eating their organic smoothie. They got their organic smoothies, and they're going to the organic cafe. So it's happening. It's all about that person taking on board and becoming taking on board the knowledge and becoming empowered for themselves.
That's fantastic. And before I ask you the final question, Bobby, if people are looking to get in touch with you or to follow your work, where are the best places to find you?
Yeah, so drbobbycheema.com is my website. It's DR for doctor, bobbycheema.com. And that's got the links to my social media and whatnot. And just send me a message on social media. It's probably the easiest way to get in touch with me personally.
Perfect. And I'll put the links to that into the show notes so people find that easy. So that brings us to our final question, and same one I ask everyone, and that is, what would you say is the biggest mistake you've made or biggest learning experience you've had that's changed the way you approach either your mindset or your career in general?
The biggest mistake that I've learned from, well, been so many. I can't really pin it down to one. I think one of my favorite authors is Osho, and he said, unless you're making mistakes, you're not growing. So I think making mistakes is all part of the process. I mean, in terms of me learning, I think the basic thing that I have learned to basically address and overcome is my fear. Fear has held me back on a number of occasions from pursuing something, this, that, or the other. We talked about challenges to getting into exercise, for example, in clinical populations. That fear exists in everyone in some way, shape, or form. So I think the biggest teacher for me has been fear and moving in the direction of my fear and overcoming that fear. And, once you move in that direction, you just realize that it wasn't that bad to begin with, and I think that's kind of been my approach in the last couple of years, is just move in the direction of my fear and get on with it. So that's been a big teacher for me.
Fantastic. And I hope that's a lesson that people can really learn something from and just learn to take the leap as such. So it's been a real eye-opening chat with you this evening. Thanks so much. And I know our listeners are going to get so much value from this conversation, Bobby. Thank you for your time.
Yeah, thanks for having me on, David. It's been a pleasure. Thank you.
So that was Dr. Bobby Cheema. If you like the show, subscribe. Make sure you're subscribed on iTunes, Stitcher. Leave us a review over there on iTunes. Make sure you hit that subscribe button on the YouTube channel if you're watching us there. Please feel free, if you liked the episode, found it valuable, share it across your social medias. Tag Human Performance Advancement in it so we can go over there and thank you personally for sharing this expert level content that we bring to you each and every week. So until next week, guys, have a great one.